Good evening, everyone. Namaskar, Vanakkam, Sasrikal, and a very, very warm welcome to this session. One more webinar to be hosted by our young infection control nurses. Before I invite Aswathy in, just give me a moment. I just want to do a few introductions and then I will hand it over to Aswathy. This webinar series we are hosting in because of the Infection Prevention Week 2024. That's already done. But we have planned for 7 webinars to be hosted by young infection control nurses. And this is the fourth in line. This is strategies to prevent SSI. There are 3 more to go. And I am truly excited to be, showcasing the young leaders, and they are the leaders for tomorrow. So thank you so much for many repeat guests who are here in the call today. You have been there for the first one on ventilator hospital acquired pneumonia, then all about extravasation, and the last one, strategies to prevent infections in acute care settings. The entire team had been very engaging, asking questions. So we are hoping that today, once again, you all are here because you are concerned about patient safety and you want to know more about surgical site infection. And soon on 25th, you will talk about cleaning, disinfection, and environmental hygiene, followed by CLAPSy, and the last one will be on ventilator-associated pneumonia. So thank you everyone for being here. Let me now invite Aswathy. Sorry. Our young ICN. First, Aswathy, a very, very warm welcome to this webinar. Can you please use yourself first and then I will share your presentation. Okay. Tell us a little
Sure.
about yourself. Yeah.
Sure. Thank you, Thangam ma'am, and thank you, Dr. Clara ma'am, for giving me the opportunity. Myself, Aswathy, I'm the nurse manager working with Gleneagles Health City, Chennai. I've been started my career from City ICU. Then I was working there for 6 years, and now currently, being an infection control nurse, I've 6 years. So I'm a Tangam ma'am. I've done 2 courses. One was Tangam ma'am indirectly involved. Second was ma'am was my teacher. So thank you for this opportunity, ma'am. Let's go to the presentation with your help.
Okay, you're most welcome and all the best. Now I will stay off audio, off video. Whenever you want me to move the slide, let me know. Okay? Right. Thank you. Ratan, please make sure that you are muted.
Yes, ma'am. I'm muted. Good evening, ma'am.
Ashwati, over to you.
Yeah, thank you, ma'am. So good evening, everybody. We are going to discuss about the strategies to prevent surgical site infection. Next slide, please, ma'am. So these are the objectives that we are going to do. End of this webinar, we will be able to know the definition, types of SSI, revised guidelines for the air condition in as per NABH guidelines, the operation theater, risk factors for the SSIs, and also the fundamental elements of accountability SSIs, and essential practices for preventing the surgical site infection. Next slide, ma'am. So this is what is site infection. Surgical site infections occurs after the surgery into the incision site. Either it can involve only the superficial, or sometimes it can even involve the deep tissues, and sometimes even it can affect organ or the organ space. We would calculate it based on 30 days and the 90 days calculation. The days are nothing. The day one is from the date of surgery. So some surgeries we will be tracking for 90 days from the surgery to see whether any is occurring to the surgical site or not. The same way, some surgeries are falling under 90 days criteria. For example, like and implantation cases. These cases we will be tracking till 90 days from the date of surgery to as kind of infection is happening to the surgical site. Next slide. So the background of the study, we can say that this is the most healthcare associated infections. Apart from any other HAI, SSI, we can see a number of cases always reported in our hospitals. Even Indian setups also, it occurs like 2 to 5% of the entire surgery numbers. We could say we have very less number, but the average rate of surgical site in Indian hospital setups is almost 2%. Also, this is the major reason why we have to be more conscious about is because it increase the hospital stay. It will be increasing the additional treatment cost will be there, additional burden will be there, even risk for the patient in mortality and morbidity. Next slide, please. So going to the next slide, we can see the types of SSI. We have already discussed like 30 days and 90 days we are tracking. The same way, based on where the infection is occurred. Suppose if it is occurred only to the superficial layer, that is skin or subcutaneous tissues affected, then we could superficial incision SSI. Same way, suppose the and the muscles are involved, then we could say we are saying it is a SSI. And other type is or the organ space, that is the infection which is reached till sometimes can be a transplant or the organ space if it is involved. It is known as organ space SSA. So as a nurse, we should know what type of SSA. Everybody knows how to track the SSAs, but we should be knowing it how many types of SSIs are there. What is our SSA? We'll go to the next slide, which we can see about wound after surgery. That is the types of surgeries. Again, we can classify it to clean, contaminated, and dirty surgeries. Clean surgeries are like uninfected operative wounds. That is wounds which we will do and surgery over there. For example, CABG, thyroid surgeries. These are the examples for the clean surgeries. The second category, clean contaminated cases, that is operative wounds in the respiratory or alimentary tract cases, like for example appendectomy surgeries we can say on this clean contaminated. Then hysterectomy cases we can say, any other vaginal surgeries we can say it comes under clean contaminated surgeries. And the contaminated we can say any open wounds, patient already come to the theater with an open wound, road traffic accident cases, these and all contaminated cases. We can say these contaminated cases we will get more SSIs. If we do an RCA, it will be a road traffic accident. They would be exposed for an the normal air. They would have been there for a long time. Then they would have brought the patient to the casualty. So it goes like that. In dirty cases includes the wound is already infected, like a diabetic wound, infected diabetic wound, or some plastic surgeries or some kind of unhealed wounds, which they are coming for continued plastic transplantations. Then again, it is coming with an infected case. Then again, they will redo the debridement. Those cases coming under dirty surgeries. So when we see SSA rates based on these types of wounds, we can say the highest rate will be definitely from the dirty cases, and the SSA risk will be for the contaminated cases, as we discussed in road traffic accident cases. And the least will be clean cases. That is, we already prepare and we wanted to prevent maximum of risk to the SSI to develop. We'll go to the next slide, which is showing like revised guidelines for air condition in operation theaters. That is, we could say certain points in that. First one is the air changes per hours. That is, it is recommended minimum 20 air exchange should happen in the operation theaters room, which includes for fresh air exchange also should happen. So this is the one point. Going to the next point shows air velocity. That is, the airflow must be unidirectional and it will be from the up to downwards. It is almost, it should cover the operation theater table, and also it is recommended the surgical team should be standing directly down to the airflow, and the velocity should be 25 to feet per minute. The force of the air which is coming from the unidirectional airflow is recommended. It should be 25 to 30 feet per minute. We'll go to the third points will be positive pressure. That is, we know it theaters is an example of pressure maintenance. Here, we are recommended to keep the minimum recommendation is to have a 2.5 Pascal pressure more than the normal atmosphere pressure. That is, the operation theater passage will be having 2.5 Pascal pressure lesser than the pressure which is inside the operation theaters. We'll go to the next fourth point, that is air handling in the OT. That is, HEPA filter is mandatory in the theaters. That is, the HEPA is nothing, high efficiency particulate air filter system. So in every OT, it is mandatory to have an HEPA system. So we'll go on to the fifth point. We can say the last point, which is that is air filtration. That is, the AHU system should be there, and it should be purification unit, and the air filtration unit also should be there in that. So we go to the next slide. The last point is the temperature and the relative humidity. The temperature of the operation theater, it is recommended to keep 21 to 30 degrees, 21 to 30 degrees Celsius. But in joint replacement surgeries, it should be 18 to 20 degrees. Sorry, it is 21 to 26 degrees Celsius. And in joint surgeries, it should be 18 to 20 degrees Celsius. And humidity should be 60%. That is, ideally, we should say 55% of humidity should be in the operation theaters. So we go to the, we can see the unidirectional airflow in the theater. We go to the next slide where we can see the image. You can see it's the how the airflow will happen from the top. So it is recommended the operation patient table, theater table, and also the surgical team, and also the which they are using for the surgery should be exactly down to the unidirectional airflow area, and the rotatory can be the, and it is also recommended if the theater is not running or there is no cases posted for your theater, it is always to unnecessarily go inside and spoil the unidirectional laminal flow. So we recommend the healthcare OT employees, if the surgeries are not there, it is not good to enter inside the theater and to sitting under the unidirectional airflow and do some other register works. So it is be strictly restricted in our hospital. We'll go to the next slides, which shows the risk factors for the SSIs. So in this, we can say, we have already said SSI risk factors include some multiple factors. It is not only one team of healthcare worker did not do well, or something went wrong by the surgical team. No, not like that. Multiple factors are involved where one SSI is developed. We can say intrinsic factors. For example, before the surgery itself, the patient is obese, or the patient is having a diabetic, or already patient is on immunosuppressive therapy, smoking. All this can be a high risk. All this will be the high risk for the patient to have an SSI. This diabetic, everybody is, any wound happen to a diabetic patient will be difficult to heal. So when we are doing an elective surgery, it is always difficult for them to get healed the surgical wound if they are having an uncontrolled diabetic. So the surgeon will be suggesting to have a diabetic, their H1AC should have a control before they plan for an elective surgeries. And same way, immunocompressive therapies. Already, suppose they are taking some immunocompromised therapy, their immunity is already less, and they are in more risk to develop or to get attracted to an infections. And next is the malnutrition. We know any wound healing, it is always required to have an additional protein index. So if they are already malnutrition, it will be difficult for them to heal their surgical wound post-operatively. Same way to the smoking, we can say for their blood to carry the oxygen, the hemoglobins to carry the oxygen will be less for the smoking patient. So it is always recommended, the surgeons, the team will be suggesting the patient quit the smoking at least 30 days before the surgery, so that we can go for an elective surgeries. Then patient-related factors like premature infants, pediatric cases, they will be in more risk to develop an SSI later. And perioperative factors related to surgical practices, we can say antiseptic preparation of the skin. If the skin preparation is not done properly before the surgery, it can be a reason where the colonized bacteria can make a problem later after surgery. Same way, time to allow the skin disinfection to dry so that recommended actions will be available even if you do the antiseptic skin preparation before surgery. And next point is antimicrobial prophylaxis. The surgical prophylaxis dose is recommended to give within 30 seconds, 30 minutes of the skin incision. That is the time of skin incision. The night time is considered as the start of the surgery. So from that time, within 60 minutes, we should give the antibiotic surgical prophylaxis. So that the principle behind this is so that the antibiotics will be having a half-life period. So it will take some time to reach into the maximum peak level of the action. By the time when you do the skin incision, by the time when the skin is exposing to the atmosphere in the skin areas will be having with that blood circulation where it will have a highest concentration of the antibiotics. That is the principle where we say the prophylaxis can help a lot in preventing the SSI, and the surgery is more than 4 hours. Then is supposed to repeat the prophylactic dose as per the surgeon's advice. And duration of the surgery, as long the exposure we are exposing to the atmosphere, the open wound, that is making a risk and SSI for this particular individual later. When we go to the next slides, we can see the essential practices for preventing the SSI. That is what are the recommendations which we say. Actually, it's looking a busy slide, but we could go through the high quality of evidence points so that we'll be able to catch up the major points. We could say administer the antimicrobial prophylaxis according to evidence-based practices standards that we have already discussed. Same way, use a combination of parenteral and oral antimicrobial prophylaxis prior to colorectal surgeries. So that we can say certain level it is identified. Use of this particular oral and the parenteral antimicrobial prophylaxis before these colorectal surgeries are helping a lot to prevent the SSI in these colorectal cases. Then decolonization of surgical patients with anti-staphylococcal agents in the preoperative settings for orthopedic and the cardiac cases. So what will happen when they do a skin preparation? The colonization, the external staphylococcus things will be get removed easily. The risk for developing an SSI will be less for them. Same way, use of alcohol containing skin preparation agent in combination with the antiseptic. That is again as per the types of surgeries. When we use it, it will be an effective cleaning of the skin. Since the alcohol is also there, it will be drying the cleaning area so that the complete effect will be applicable. And the same way, next we can say like the procedures, if suppose the surgery is not maintained in hypothermia, those cases we can maintain the normal temperature. It is not necessary every cases should maintain a hypothermia during intraoperative or immediate postoperative. Same the way. And do not remove the hair, which is not recommended. As we, how much it is recommended by CDC, the scrubbing the razor should not be used to prepare a cervical skin. It is always recommended to do a clipper over there. But even if we could say that, even if it is not recommended, it is always good to leave that as such. If the requirement is there, if we got a guide recommendation that skin preparation should be done before the surgery, then we can go ahead with. So every time in preparation, when we remove the hair, always the risk to in later period is more, because there will be micro cuts on the skins which we can't see naked eyes, but the same area where we are going to do a surgical incision, it will be more risk for the individual, that is to the patient, to develop an SSI immediate postoperative. We'll go to the next slides which indicate the essential practices continuation points, which we can see here. Use impervious plastic wound protectors for the biliary tract surgeries. So it will be it's an evidence, but all the hospitals are not started implementing it. Again, based on the surgeon's preference, 1 or 2 hospitals in we are started to using it. And other one is control of blood glucose level during the immediate postoperative period for all the patients. That is Soon after the surgery, for the next 24 hours, the glucose level should be in complete control. That shows be helping. It will not allow any pathogens, suppose by mistakenly gotten exposed to the cut area. If it is with an uncontrolled sugar level, the possibility for to grow in that particular site is more. So it is very important to control the blood glucose level to the immediate postoperative period. Same way we can say you use alcohol containing perioperative skin preparation agent. That is we have already discussed. So it will be helping certain level to dry out also immediately. So that complete effect will be available. So when we go to the next slides, we can see the risk factors and the recommendation for them, or how evident it is. So it is like some are unmodifiable, some we can modify it. So if unmodifiable, we could say like age, history of radiation. If the patient is already an onco patient and they have undergone multiple radiation cycle and they have come up with some other cardiothoracic surgery. So the patient is already on risk to develop an even if we do an chest incision. So, and history of skin and soft tissue infections. Already the individual, the patient is having a skin and soft tissue infections. We should know them. They are in a more risk to develop an SSI. These things we can't modify. There are some risk factors we can modify. That is, as we discussed, glucose control can be modified. Obesity, if the patient is obese, the surgeon will be definitely advising them to have a control on weight control before elective surgeries. Smoking sessions we already discussed before. The surgeons usually will be advising, the nurse also will give an education to the patient in the OPD. When you are planning for an surgery, it is always recommended to stop smoking or quit smoking for minimum 30 days before they are getting admitting for a surgery. And next we can say like the hair removal. If it is recommended, do it. If it is not recommended, if that is not mandatory to do a hair removal, leave it as like that. We'll go to the next point, which we can, with next slide, we can see the operative characteristics. What are the risk factors in operative areas we can prevent it? That is skin preparation, very mandatory. The skin preparation is not done properly. It is risk to develop later. When we get in cases, gynecology and cases, they are landing with an methicillin sensitive staphylococcus aureus. Or sometimes these gynec cases will be landing with MRSA, methicillin resistant staphylococcus aureus. So all these staphylococcus team would have arrested if the skin preparation properly. In certain level, we can prevent it. Same way, antimicrobial prophylaxis, then operative timing. As long as surgery is keep on going, the exposure time is more. Developing the surgical site infection to the surgical area is more high. Then next we can say operating room characteristics. The risk factors where we can modify is, one is we can say sterilization all surgical equipments. That will be definitely we will be doing that. The preparation of the sterile trays, proper sterilization. If the flash autoclave is required, then go for that. Then surveillance, ICU and OT surveillance for the operation theater before planning the surgery. So all these preparations we could do it so that at certain level we can prevent the risk for the SSA to the patient. So we'll go to the next point. We can next slide. We can see reducing the operating room, how it is going to affect, or how it is a risk factor to develop an SSA. We can say the dynamic of OR traffic includes the door opening and the number of individuals entering inside the room. Either it can be the surgical team, it can be a scrub person. Mostly it will be an additional healthcare worker who is working inside the theater. Second point, when we go to the second bulletin, we can see direct observation related to the OR doors. We can say like approximately 20 times in an hour. That is 18. We now make it to 20 times the doors are opened and 20 individuals minimum are entered inside the theater every 1 hour. So that itself is making a problem, because as we discussed, the theater rooms will be maintain the pressure difference of 2.5 positive Pascal. So the pressure difference inside the theater and the OT passage will be having a 2.5 distance. So this will get affected where it can be, if the doors can be keep it closed. We can go to the next point where it says, reason for the overhead traffic includes supply of the retrieval of equipment, additional equipments if it is not kept it ready. There is the preparation of the materials can also cause the continuous traffic.
14.
So when you go to the next, we can see overall the find goes the significance of monitoring of the operation room traffic. That is also directly contributing to develop an SSI. So when go to the next point, that is that next bulletin shows like optimal surgical outcomes by implementing this. That is the healthcare facilities can effectively mitigate infection risk. Like in sense, we can say the limiting the entries to the rooms, or some the staff box can be reduced. We can reduce a number of traffic of operation theater rooms by only opening the pass box. We can only give the required materials in case we need an additional material from outside the rooms, like that. So when we go to the next point, we can see next slide, we can see the fundamental elements of accountability and engagement for SSA prevention. It is like everybody in the organizational role has a certain responsibility, and we have to take the accountability. If suppose one individual is blaming that this is not because of me, surgeon will be blaming, no, I have done a perfect transplant of heart transplant case. Then how did problem? The nurses team will be telling we have taken care of very well. No, it's not. Everybody has to take equal responsibility for any accessory which is happening to the patient. If the senior management, they should make sure ensure sufficient fund is there, sufficient PPE is there, required appropriate HA tracking is happening. All these things are responsible of the senior management. Same way the surgical service leadership, that is the surgeon teams, they have to ensure all the perioperative staffs are aware about their roles and responsibility. If it's a new staff, they are not at all supposed to help or go next to the surgical table. They can only watch, they can only observe it. We have to give them a limit. This is the area where the pressures can't come out. We have to observe for this duration or 1 week, 1 month, whatever it is, based on the organization policy. We can guide them properly so that they know what to do, what to do not do. And surgical service staff, that is a surgeon, anesthetist, and all, ensure execution of prevention of measures consistently for all the procedures. Not only like today's first case, they have done all the precautions. The same precautions which they have do from the first case in the morning, they should follow the same as much precautions till the last case which they are planned in the 6 p.m. And pharmacists, they should make sure all the surgical prophylaxis medicines are available due the dose should not delay. Infection preventionist, we should be making sure all are done properly, all the data are tracked properly, and environment service staff, they are make sure the housekeeping will be making sure in between the surgeries the rooms are cleaned properly, the equipments are cleaned properly, the in between the patients the rooms are again cleaned, and before they're taking to the next cases, that should be followed. And information team, that IT can track in collecting the SSI details and the call details, the number of surgeries happen, so that the managers and the infection preventionists can be tracking in a different way to make sure any SSIs are there which is not reported to the hospitals. So here we'll come to the last, we go to the summary. The next slide shows the summary, which we can say SSI is actually a small but significant cause of morbidity and mortality after surgery. Actually, it is preventable if we follow all the adherence and to establish the guidelines. So if we follow it, actually we can prevent it. And it's also an economic burden for the patient and also to the hospital, and causes this multifactorial. It's not like one individual is the reason for the SSI. It is everybody who is involved in the healthcare system, who is part of this operation theater or to the surgery, are responsible if the individual, if the patient is landing with an SSI. Thank you.
Aswathy, I must agree that was a marathon, sharing. maybe the participants sitting here, they would have questions. So one of the questions that I heard was that, what is the surveillance for SSI, non-transplant and transplant? Would you like to answer that?
Yeah, sure. Surveillance for the transplant and non-transplant. Obviously, for the transplant, we'll have to do an additional precautions, like the cleaning and every again based on the organization policy. Transplant ICUs will be doing an OT surveillances culturing in every 3 months once. Whether the we are running the theater every day, or whether we are running the theater twice in a week, every 3 months, the surveillance should be done. HIC room surveillance should be done and it should be tracked. And the other way we can say in non-transplant cases, any surgeries we supposed to track it. We have to call them. Either we can track it from the OPD visit. Second, we can track it through the call system. So every cases after discharge, we can call them and one person either can be infection preventionist or some link person or from the operation, we can get help from the operation team to call them and ask whether you have any symptoms of this SSI, so that any cases should not miss out, which has undergone surgeries in our hospital.
Question is about SSI tracking. Non implants are for 30 days and implant is 90 days. They are just trying to verify. So there's a question that NABH assessor only. See, first of all, please understand NABH assessors are also people like you and me. So we should be thorough with what is the evidence-based guidelines which is available. So whatever the assessor says, you don't have to accept it. But blindly, this I'm telling you very, very honestly, if you are very sure about the guidelines, because the guidelines today, the CDC guideline talks about 30 days of any post-operative infection. It is called a hospital-acquired SSI if within 30 days. So you will have to follow up the patient for at least 30 days. And if they are transplant, earlier it used to be 1 year, now it is reduced to 90 days. So for 90 days, you will have to follow up and ensure the patient hasn't developed any surgical site infection based on already Aswathy explained the types of infection that you can have. You need to also ensure that you are aware what type of SSI they have had also. So I think that answers your question. Now somebody is asking, is there any checklist for surveillance? It all depends what kind of surveillance you are doing, whether you are doing environmental surveillance. That's what Aswathy mentioned a little while ago. So I will be asking a question. So, okay. I'll ask a question. The checklist can be, there are many checklists that you can have, whether it is on the infrastructure, whether it is on the process, or whether you are going to do a retrospective audit on the SSIs. In case you have SSIs happening in CABG, you may like to do a retrospective file audit and plus some other audits that is required to be done in the records of the biomedical engineer. What was the temperature, the humidity that was maintained in those OTs at that particular time. So today's information kind of showcased everything, but then every little line item would have to be dealt with based on the kind of problem that you are doing. What is the correct choice for SAP? I don't know. I am zapped. I don't know what is SAP. What is SAP? Do you know what is SAP? I have no idea. Can you please expand the short form, please? What is the correct choice of SAP? I don't know. Do you
Ma'am, surgical antimicrobial prophylaxis.
Oh my God, you create your own abbreviations, then it is a problem, my dear.
That
It's simply called as surgical antibiotic prophylaxis. So I have never seen this abbreviation. So that's another shout out to all of you. Please don't make your own abbreviations. If they are not used anywhere in the standard guidelines, please do not do that. The correct choice of surgical antibiotic prophylaxis is based on your hospital. It's based
policies.
on your antibiogram. It is very important that your own hospital should have your own antibiogram based on the kind of, cultures that is being developed there. But there are some standard guidelines which are available as treatment guidelines, but then your hospital infection control committee has to release documents which says for this surgery, this is the antibiotic and this is the route, and for this long it needs to be given. The 60 minutes prior one, definitely that, as Ashwati explained, the antibiotic should be given within the 60 minutes of the incision. And if the surgery is going longer, there needs to be a redosing of the antibiotics. So as an infection control nurse, you have to look into many different areas when you are looking at the SSI. So of course, when you do a root cause analysis, you are going to get into all the topics that, Ashwati mentioned, the structure, the process, the patient, everyone, every single aspect of it has to be, looked into when you're doing a, root cause analysis. My question, I was going to ask a question. Now I forgot what I was supposed to ask because I got into something else. Yes, we can take more questions. We still have some more time. Because Ashwati was like an express train. I totally understand. She just switched on and she went like that. So if you want any points to be expanded or elaborated or rediscussed, please let us know. Can you throw light on maintaining hypothermia? So let me try to explain that, and Ashwati, you can add to it. See, hypothermia should be only for those patients who needs intentional hypothermia for the surgery. For example, for like CABG, patient is on bypass, it is an intentional hypothermia. Otherwise, all the other patients are expected to be kept normothermic. And there is evidence to say if colorectal surgeries, if you don't keep the patient in normothermia, they have higher risk of surgical site infection. So it is very important to know whether the patient needed hypothermia because of the nature of surgery. Then it is okay because you can't do anything. You have to use the cold blanket and bear. You have to make sure the patient is kept cold. There are only few surgeries where intentional hypothermia is required. Otherwise, all other patients are supposed to have normothermia. Correct? Okay, another question. If there is no case in OT, the HEPA should be continue or not? Would you like to answer?
Yes, ma'am. It should be. It should continue because, as we said, this flow and the filter system and humidity, everything. If we stop it, actually, the study says the risk to develop and to have an uncontrol on these setups will be more. So that is the reason. Even I specified even transplant cases. Every day we might get a we will not get a transplant. Sometime in all hospitals we will not have an everyday transplant. But still, the HEPA filter system, the humidity and the AC should be kept on. So this is the recommendation because when we try to collect back all the setups, once we off, then it will not be as we expect. So that is the reason we have to keep everything on, including the AC.
Yes, I'll tell you a little story about that. A long time ago, I was actually facing the NABH assessment. I was the NABH coordinator. So the principal assessor, so he was actually in the engineering department. I was just following. So he kind of asked the biomedical engineer. So he said there are a lot of lights no on the panel, which OT and all that. So he was asking him to explain. So he explained all that, and then he saw one OT, the light was off. So I knew there is trouble. Okay. So he asked that why this OT is off. So he said, because there is no surgery. Oh my God. We definitely had a PC for that because, and then, so that's a big lesson I learned that, you cannot, as an ICN, you really cannot leave any department out of your purview because they are not the specialist in infection prevention, though they know that this is what needs to be done. So it is very important to have guidelines around biomedical engineering that when can you put the OT off and when the AC should come on. So idea is whether your OT is there or running or not, your AC should be on because the air will. Another very important thing that Ashwati mentioned, it is still a problem. In number of times the OT door opens and people going in and out. Though the OT itself is under positive pressure than the corridor. That means when the door opens, the air will go from inside the OT to the corridor. It is planned like that. But when you open it too many times, obviously the temperature, everything can have an impact because too many people, too much of air circulation happening. So this is actually a very good observation, a simple observation you can do in your different OTs to see that how many times the doors are being opened. And I have done this study many years ago, and I was also surprised. I think 16, 20 years, big number, the same double digit. So that is one recommendation to see that why are they coming out too many times. And the administration has to ensure that they are not having that opportunity to go out too many times, because you should have everything inside. When you don't have what is required inside the OT, that's the time people are going to run in and out. So as administrator, ICN can find out why they are going, and then the organization should support to ensure that all items are inside the OT. So I always tell all the ICNs when I train, or there are many leaders sitting here, ICN is a very, very critical role in any organization, and they are like detectives. They will go and find out what is going wrong. Okay. Now there is a question about flash sterilizer. Is it advised? Can you answer that, Aswathy?
Sorry, ma'am. The question.
Flash sterilizer.
Okay.
Flash sterilizer.
Yeah, I got it, ma'am. I'm just opening it. Okay. In this, whether flash sterilizer advised, as I understand, quality check is difficult for flash. It is based on the type of surgeries. Only if something in emergency, we can say something where we have only one, where we need, especially in orthopedic cases. So those time in our organizations also we will just get a help of flash autoclave, but we should have a proper tracking of the materials, how frequently we are using, or are we using a multiple times than we like that. So we should say that if it is required, we can go ahead with, but the surveillance also should be done frequently based on your organization policy.
I would like to add that, try to reduce, that is the recommendation. Flash sterilization only should be, in case of any emergency thing. It should not be a routine thing that, I can flash everything. So that's a record that needs to be maintained also in the OT, that what equipment was flashed. I mean, they call it as flashing, what equipment was flashed and why was it flashed. So that's actually a quality assurance process you can have in the OT, that what was flashed and for what purpose. So if you can see that those equipments were really not required to be flashed, you need to find out why they are being flashed. Maybe they need more so that they can have sterilized equipment, or they can have spares so that in case, something needs to be replaced because of whatever, or something dropped, whatever it is, flashing is not desirable. That's all, the one needs to be kept in mind. It is to be used only in emergency. So there is no recommendation to use flash as a routine thing. So then what is the time frame to send ETCS? What is that ETCS? Another
endotracheal culture and sensitivity. Yes, ma'am.
We are talking about SSI today. So we will take this call when we discuss VAP. Okay. Today we are talking about surgical site infection, so we will not take those questions. Okay. So explain skin prep. Asking about skin prep. Would you like to repeat that once again about skin preparation for surgery?
Yeah. Ma'am, what was the question on skin preparations? No? Because
I
can
just
you just
asking surgical skin preparation. Surgical skin preparation.
okay? So the surgical skin, we could say in two phases. One will be preoperatively when the patient admits to the ward, either if it is chlorohexidine based or we don't give the betadine nowadays, but chlorohexidine based surgical skin total body preparations can be done in the ward itself overnight. That is one. The second one in the theater, again they supposed to do the skin preparation, either it is with a chlorohexidine or the betadine. But if it is a betadine, the thing is we have to give an dry period, that is the minimum, or else we can say 3 times of cycle of scrubbing. One scrubbing complete area, followed by the second cycle of scrubbing. By the time the third scrubbing the area, so it is assumed till the third scrubbing, between the first scrub, it will be minimum 3. So that should be followed so that the complete effect should be there. Or else if it is chlorohexidine, it is highly, the evidence says if we do a proper skin preparation, it is the SSI risk is very low in these cases. Or if there is a bypass in the skin preparation, especially in gynec cases, we could see if the skin preparation is not done with giving a proper timing with chlorohexidine, definitely we can say that there is a multiple SSA risks are observed those cases from the particular specialty alone.
Have you answered that question? Minimum dry period. See, it's very important to remember drying of different disinfectants have different recommendation, because alcohol will dry faster, chlorhexidine will take a little bit more time, and betadine is going to take a little bit longer time. So the recommendation always allow it to dry. I mean, whatever time it takes for the disinfectant to dry, we have to ensure that it is dry. This is very important. And Ashwati did mention about what is that sheet called? That
Microbial.
antimicrobial sheet is being used on certain surgeries to ensure that, when the surgery is happening, there is a continuous cover of the, disinfectant that is being there, because that is why these sheets are being recommended. So I hope we answered the drying period. Now there is a question, what is the management of SSI in case of post-cesarean section mother? Now, I don't think it is any different from any SSI happening in any other surgery. And obviously, as per your recommendation, you will give antibiotic to dress the wound and keep it from getting worse. The same recommendation for any other SSI. I don't know of any other specific SSI. There will be guidelines which says that which antibiotics work for this SSI. The cesarean, CABG, transplants, all these surgeries are not supposed to get surgical site infection. So that is really something one must get into to see that why these patients are getting SSI, because the literature kind of indicates that in surgery, in these kind of surgeries, if you have SSI, there is a problem with the process of the people or something is not right. And in US, the CABG with low risk, if they get SSI, it is called a never event. You should never get infection. So what does that mean? Never event means if it happens, the insurance company will not pay for the treatment of that SSI. In India, it is not yet there. So it is very important to be borne in mind that, some surgeries are ultra clean. They are not expected to have surgical site infection if the patient's risk is not that high, because patients are also stratified for surgery, correct? So there will be in the ASA score of, 1, 2, or 3 based on that. So you need to keep a watch that, who is getting SSI and whether it is risk stratified. After risk stratification, is there some commonality happening in those patients? This is very important to be kept in mind. if the antibiotic started same day of surgery, this can be surgical prophylaxis? No. Same day
No,
of
that
surgery is not known as surgical prophylaxis. Correct, Aswathy?
yes, ma'am. In these cases, we could say that's a therapeutic dose is already going on for the individual. So we recommend let the regular doses go. Then based on that, if the surgery is more than 4 hours, as per the surgeon advice, we will be giving the additional dose as a considering as a prophylactic dose. But it will be parallel to what the therapeutic dose is going on.
Obviously, that's the correct answer. And moreover, please understand the antibiotic that is being recommended, the redosing is based on the half-life of the antibiotic.
That's the
So,
first dose.
yeah, the first dose is given, second dose will be based on the half-life of the most of the drugs, they will be having peak level within that 60 minutes when you are actually cutting the body. All the tissues are very saturated with the antibiotic. It's like a picture you can have in mind, all antibiotics are there like soldiers waiting, okay, no infection will come now, you are cutting the body open. So that is why the 60 minutes recommendation is there, because that's what the research has proven, right? So that's why that time is very important. So many of the hospitals are shifted to giving the antibiotics in the OT itself, so that you are sure you don't have to redose. Otherwise, what used to happen before, you will give the surgical prophylaxis in the ward because the OT called, and then by the time the patient reaches the OT and gets into the incision, already that time window is gone. The 60 minutes is gone because of many other reason, logistic reason, patient's reason, whatever it is. So this needs to be kept in mind. It is not a question of giving antibiotic before surgery. That before surgery has to be 60 minutes to the incision. This is very important because you have to, when you do the audit, you have to audit the OT sheet to see what time the incision was given and what time the surgical prophylaxis was given. And that has to be within the 60 minutes window. Correct? This is very important. Once you understand the guidelines, when you start looking at things closer, want it to be very, very clear that this is what we are trying to look for. Okay, I think any other questions? Thank you for, being so engaged and asking many questions. Is there any more questions? We still have few more minutes before we can wrap it up. No more questions? Okay, there is, if you Google, you will find the NABH guideline on OT. It's freely available. I just downloaded it, but then I'm not able to share it here, not able to do it very quickly. Please download that guidelines. That's a revised guidelines from 2018. That's a good place to start to see that, what does NABH talk about, OT. So your temperatures that is mentioned is 21 degrees centigrade plus minus 3. That is what it is. I think by mistake, Aswathy, can you see the temperature slide again? I think it was in 3 digits, if I'm not mistaken.
Yes. 2-digit it was, ma'am.
210 or it was 21?
21. The higher limit was by mistake was 30. Just minus.
Yeah, just repeat that temperature thing once again, because I thought in the slide there was a mistake. Yeah.
So the temperature, the room temperature in the theater, it is recommended to 21 to 26 degrees Celsius. In normal cases, if it is joint surgeries or any joint replacement surgeries, then we could say 18 to 20. That is even more 3 degree lesser than the normal cases which we could maintain. So in joint replacement surgeries, we can say 18 to 20 degrees Celsius, and other cases 21 to 26 degrees Celsius. And humidity, we could say 20 to 60%. So average, we will be saying like 52, which is there 50, 55, then it is, we consider as a normal humidity in the theater rooms.
So okay, the practical question I had is you are getting a call. I mean, you know that your temperature has to be kept between 21 plus minus 3. So 20 to 24 is what you are asking. And for, transplant or joint replacements, you can have it little cooler. So in other cases, the surgeon, many a times they feel very warm. So they will say, please reduce the temperature to 16 because they are wearing PPE and everything. So I would like to ask the group that, when such requests come, what are we going to do about the patient? Because we know that the patient has to be normothermic. He cannot be made too cold, right? We know that. So what do we do? Practical answers, please, because you cannot tell the surgeon, sir, I cannot reduce the temperature because this is the guideline, you feel hot. Then he will start to sweat because many surgeons had this request when I was in the hospital, So, okay, thank you. So Jarin said, warm
We
blankets. Yes,
warm,
that's
apply the warmer, warm blanket.
it's very important to remember that we need to balance. The idea is that the temperature of the patient should be normothermic. Now, when we did an audit, it was a very interesting finding that there was no regular documentation of the temperature in the anesthesia chart. It was a finding. Even the chief of anesthesia was, shocked. He said, I did not know. I said, yes, there is no regular charting of the temperature. There is no regular charting of the blood sugar. So intraoperative sugar and temperatures are very important. And if it is not being, monitored, that means there is a lapse in the process. So this is also something that one must keep in mind, that we should be able to. So then we realize the patient's temperature needs to be monitored, and then we ensure that patients are available on warm blankets, We actually had bear hugger moving to OTs so that the patient can be kept warm. So these are some of the, problematic area that we might overlook. And there is enough and more evidence coming again and again, especially in colorectal surgeries, that you have to maintain normothermia. Now, Ashwati, I'm not very sure. Did we discuss about giving supplemental oxygen in the post-op area? Is there a recommendation did you find in the document? Or I would also like to ask all the people sitting here, do you
We
have a
didn't add,
yeah?
we didn't,
Your voice is breaking. So all
we
of you,
didn't add.
no. Are you practicing? Are you giving supplemental oxygen in the post-op area for all patients? Are you giving?
We do give based on the type of surgeries and how do we give the anesthesia to them.
So there are this document that Ashwati has referred is not the WHO one. There in the WHO there is a very exhaustive document which talks about surgical site infection and what all can be done. So there has been some evidence that the patient, if they are given additional oxygen in the first, 1 or 2 hours of postoperative period, whether their saturation is normal or not, that has no meaning. You did mention about the hemoglobin, right? You mentioned about the hemoglobin. The hemoglobin has to be right. The patient's blood loss must be monitored because if patient is losing blood, obviously hemoglobin will fall down and the oxygen carrying capacity of hemoglobin will come down. And so obviously to mitigate all these things, your supplemental oxygen has been recommended in the WHO. In the guidelines that you looked for, it was not there, right? Yes?
Yeah.
Maybe it's a good idea for those who are sitting here to discuss with your anesthesia heads also that what is the stand on giving supplemental oxygen. And please check in the postoperative area because you never know, maybe they are giving oxygen to all the patients. Unless you get into the recovery room, you will not know whether they are giving or not. So it is important. So in a hospital, when patients used to come back, there used to be an order give oxygen for 2 hours. When those days, there were no recommendation like this, but now I have read this recommendation in WHO. So if any major loss of blood, clinical issues, then they are giving supplemental oxygen. Okay. Colorectal surgery is a very dicey surgery, and that is where, a lot of focused guidelines are available that for colorectal surgeries, you need to do like this, you need to do like this. Please, continue to keep in touch with the latest guidelines. This is very important. And hope that the session had given you more to understand and learn and where to look for trouble in case you are facing any SSI issues. Yeah. Sedation score also one parameters. Yeah, that is, the sedation score is to ensure whether you are giving any, you need to give any additional oxygen or not. I understand that. Okay, great. So if you are all happy with Aswathy's discussion on SSI, please give her a thumbs up. I was sharing the PPT, so there was a little bit of technical glitch because I was also trying to admit people and I was also trying to share the PPT. So it was not a very smooth transition. So there's lots of thumbs up coming. So thank you, Aswathy, for taking this session, and God bless you and take care. Continue to do a great job as an ICN. And I am very sure that you are a very passionate ICN. So uh, keep it up. Continue learning. Okay, great. Thank you, everyone. And we had a good number of people here. There's a lot of leaders also came in. And keep your passion for infection prevention for our patients. And then we will see you all now on 25th. Yeah, a lot of webinars back to back. So 25th, we are going to talk about environmental hygiene, cleaning, and disinfection. Okay. Thank you, everyone, and take care and good night. Thank you for your appreciation. Thank you very much. Take
Thank
care.
you.